Good morning and welcome. Good morning and welcome. Happy Friday, everybody. We'll give it just a few minutes to get started, as always. Good morning and welcome. Feel free to drop your name and your organization into the chat. Desiree is already doing it. Thank you so much. That way we know who's here with us today. Good morning and welcome to everyone who's just joining us now. Thanks to everybody who's dropping their names and organizations into the chat. If you haven't done so yet, feel free to go ahead and do that. We'll get started in just a minute or two. We'll give folks a chance to settle in. We have a very timely group this morning. Congratulations. We'll give it just one more minute. Good morning and welcome to everyone who's just joined us. Let us know you're here. Drop your name and your organization into the chat. Wonderful. Good morning. Good morning, Luz. Good morning, Sonia. Hope everybody has their coffee nearby if that's their pleasure. We will take a quick break in the middle if you want to refill that, and we'll go over housekeeping in just a minute when we get started. Good morning. So I think it's time. Let's go ahead. Good morning, everyone, and welcome to today's webinar. My name is Laura Brooks, and I'm with the Community Mental Health Board of Oak Park Township. For those of you who are new to our professional development workshops, welcome. For those who've been here before, welcome back. On behalf of the Mental Health Board and River Edge Hospital, thanks for taking the time to be with us this morning. In addition to our speaker, who I'll introduce in a moment, I'm joined here today by my colleague from the Community Mental Health Board, Melissa Lobring, as well as by Fatima Villasenor from River Edge Hospital. Before we get started with today's workshop, we have just a few housekeeping items to go over. First, our speaker would like this to be an engaging workshop. If you haven't already done so, please feel free to introduce yourself in the chat, just your name and your organization. If at any point today you're experiencing any technical difficulties, please chat the hosts and we'll do our best to address it. Next, our presenter has saved some time for Q&A. If you have a question for him, feel free to drop that into the Q&A so we don't lose it in the chat. Also, he has built in a brief break midway through today's presentation. So we'll all have an opportunity to step away for a little bit to grab a coffee or a tea or refill your water or just stretch, do whatever we need to do to get ourselves straight. Finally, and importantly, I want to cover our CEU procedures, which are changing just a little bit starting with this workshop. As always, to be eligible for CEUs, you must participate in at least 75% of today's webinar, and you also must fill out an evaluation by the deadline. Due to requirements implemented by the state related to CEUs for virtual workshops, you will now also have to complete a post-test, passing with a score of 80% or greater within 3 attempts by the deadline. So we'll post a link to the evaluation and to the post-test in the chat at the end of today's webinar, so you'll be able to fill them out immediately if you want to. We will also email a link to the evaluation and to the post-test later today. Both will be open for 1 week through August 15th, Friday, August 15th. After the evaluation and post-test close, CEU certificates will be emailed within 2 to 3 weeks to those who attended at least 75% of today's webinar, submitted an evaluation by the deadline, and passed the post-test with a score of at least 80% in 3 attempts by the deadline. If you have any CEU questions, please feel free to contact the organizers through Eventbrite. Okay, without further ado, let's get started with today's presentation. We are so pleased to welcome back to our series Dr. Orson Morrison to present his workshop, ADHD, Understanding, Assessing, and Supporting Clients. Dr. Morrison is a licensed clinical psychologist, consultant, educator, and the co-owner of Lifespan Counseling and Psychological Services, a group psychological services practice. He is also the associate director of the DePaul University Counseling and Psychological Services. Dr. Morrison has worked in a variety of clinical settings, including college counseling centers, community mental health centers, inpatient and outpatient medical settings, private practice, and academic clinical research units. He has also taught graduate level coursework in psychology and offers trainings to the community on a variety of mental health topics. Dr. Morrison's professional interests and areas of expertise include psychotherapy with children, adolescents, adults, and families, racial and intergenerational trauma, psychological assessment, and contemplative practices. His approach to clinical leadership and practice is underpinned by a commitment to social justice, multiculturalism, inclusivity, and anti-racism. In today's webinar, with an understanding that clients often present with symptoms of attention deficit hyperactivity disorder in clinical settings, Dr. Morrison will review up-to-date research and clinical knowledge on ADHD and cover topics such as the identification, assessment, and treatment of ADHD across the lifespan. He will offer practical strategies that can be helpful in supporting clients with ADHD in clinical and non-clinical settings. And with that, I'm pleased to turn it over to Dr. Morrison.
Thank you so much, Laura. Such a pleasure to be here today with all of you. I imagine most of you are from the Chicagoland area, but wherever you are, welcome. It's really a pleasure to be invited by the Oak Park Township Community Mental Health Board and River Edge Hospital to talk about today's topic of ADHD. Just a little bit more about me in terms of what I'm presenting the framework from where I'm presenting from today. I've been doing this work for 20 plus years, almost 30 years, which is kind of hard to to say out loud. But I do a lot of therapy work, but also a lot of assessment work. So ADHD is one of those most common presenting concerns that I see in my practice. And so over the years, I've really had to learn about the disorder and stay up to date with the research. I'm also a husband and parent, local Oak Park resident, and I bring my own experience raising kids, etc., to these sorts of talks as well. Just a reminder that I am a clinical psychologist, and I will be throughout the presentation referring to topics like medication, for instance. And so just a reminder that I'm not a prescriber, but, as a psychologist who works extensively with folks with ADHD, I've sort of, learned and kept abreast by reading and staying up to date with the research. So I'm going to be talking mostly from those perspectives. Throughout today's talk, I'll be sort of referencing research, and I did include a reference list at the end of my PowerPoint slide. I will be sharing the slides for you all. So after today's talk, I'll be sending a PDF over to Laura, and they'll get it to you somehow. So you'll be able to dive into the research in more depth if you'd like. All right, so today's outline, we're going to cover, what is ADHD? We are going to look at, kind of the diagnostic criteria of the disorder. What are the things that we should be thinking about as we are gathering information, as we are trying to make those assessment decisions around ADHD? We're going to talk about some of the etiologies of ADHD, the underlying causes of ADHD based upon the research. And the bulk of the presentation at the end will focus on strategies, how to support those with ADHD in clinical settings, but also in non-clinical settings like work and school. All right. So why is it important as clinicians to continue to learn about ADHD? First of all, ADHD is an incredibly common condition and impacts approximately 3 to 6% of the population. Prevalence rates are sometimes cited as higher in the research or lower in the research, depending upon the study. But there have been some studies over the last 5 to 10 years even that have suggested that ADHD is on the rise. And some possible explanations include the fact that we've sort of just come out of COVID pandemic, for instance, and that time uh, allowed folks to kind of slow down a little bit and maybe notice the symptoms more prevalently in the home environment. I know many of us have clients who reported really struggling with, for instance, online learning, having a real hard time just sitting in front of a screen all day and working in that manner as well for adults. And so, that particular time in our history made it more likely for folks to start recognizing the symptoms. We have also had a lot more awareness occurring in our culture around mental health in general. But also, ADHD in specific. So we are talking about these things in more depth, and there's less stigma around these sorts of things. And so, that's probably why we're seeing more and more people presenting with those sorts of concerns in our clinical practices. Um, the prevalence rates, many suggest that those are even lower than the actual rates occurring in our population. There's been research suggesting that fewer than 20% of individuals who have ADHD are accurately diagnosed. And fewer than 10% of those with ADHD are actually treated. So it's really important for us to, as clinicians who might see folks on the front line, to be thinking about, these sorts of conditions and to raise awareness in our communities and our families around these sorts of issues. It's also incredibly important to recognize the debilitating nature, the potential debilitating nature of the disorder. There is broad research out there that documents the clear public health impact that ADHD can have on a person's life. And then sometimes those impacts can be quite severe. So it really is a public health imperative for us to take this disorder seriously and to provide supports and treatment to those with ADHD. It's also a very a treatable condition. So, despite the potential severe impact this sort of a disorder can have on a person's life, on a positive side, it is one of the most highly treatable psychiatric conditions we currently have supports for in our field. So that's a really important reminder. And another reason to continue to learn about uh, ADHD, you know, um, is that the science around ADHD is rapidly changing. And that's really in response to advances in brain science, how we understand the brain, how we're able to, use neuroimaging techniques to really understand what's going on in the brain neurochemically. We're able to see how certain structures of the brain are functioning, how they're, what levels of activation are, how they're connecting to other parts of the brain. And so we've really, over the last decade or so, had incredible advances in our understanding of this condition. So it's really important to keep up to date, keep abreast of the science and the research around this particular condition. So what is ADHD and why is it considered to be a disorder? So over the years, I've heard like a number of analogies or metaphors describing what it's like to have ADHD, and I'm just going to share a couple here. But I've heard that ADHD. I've heard this from clients, and I've heard similar metaphors in other settings as well. But ADHD is like opening a web browser and having too many tabs open, right? And we start to forget, if we have duplicate tabs, have we opened the same tab multiple times? We keep opening, we keep opening more and more of these tabs, and we sort of lose track of like what's open. And if we open too many of those tabs, the system becomes sort of overwhelmed, and our web browser might freeze, right? So that's a really, I think, a really good analogy. I've also heard another one where ADHD is like imagining yourself in the middle of the ocean in a boat, and you're in an incredible storm, really big waves, and you're trying to thread a needle, right? So you can imagine just all the things, all the distractions, all the difficulty sort of regulating your balance, and all of these sorts of things that would make it really difficult to complete that task. So those are some analogies or metaphors that can help us sort of understand what it's like to actually have ADHD. So ADHD is really now recognized as the most commonly recognized and treated psychiatric disorder in childhood and adolescence, and is increasingly so in adulthood. We're getting more and more research out about how ADHD presents in adults. And in order to help us understand the diagnostic criteria for ADHD, I'm going to take in a moment, just I'll walk you through some of the DSM-5, which is our most recent version of our diagnostic and statistical manual. I'll walk you through some of the criteria and research updates there. Um, ADHD is really about having difficulties regulating our reward and motivational systems. And we will look at some of the etiologies around ADHD. The ADHD is now very, very well established as a neurogenetic disorder. So it impacts how our brain circuitry, how brain structures work, and there's also a very strong genetic component, which I'll dive into a little bit later. Um, Traits are um, on a continuum, right? So the traits associated with ADHD, such as our ability to regulate attention, our ability to regulate our impulses, fall on a continuum. These are traits that all humans have, but our functioning varies. Some people are at the extreme end of those continuums and have real difficulties regulating attention and inhibition. And ADHD is considered a disorder as we approach the more severe, impactful impairments, right? So we don't only want to, we don't only have the symptoms. We also need to show that there's been adverse consequences or impairments in the quality of our life in different settings. So at home, at school, at work, in order uh, for that classification of disorder to be met. All right, so let's look a little bit more deeply at these two traits. ADHD is a two-trait condition. Symptoms fall into two domains: the hyperactivity impulsivity domain and the inattention domain. So let's start with the hyperactivity impulsivity domain. In our DSM-5, there's a list of 9 symptoms that fall under this domain. Some of those symptoms include fidgeting, tapping, being really squirmy, difficulty remaining in our seats, maybe running or climbing when inappropriate, difficulty engaging in activities, leisure activities, etc., in a quiet manner. Feeling like we are just driven by a motor, like that there's this internal motor that just will not stop. Um, we may talk excessively in social settings. We may blurt things out. It's a lot of these sort of verbal impulsivity. We may interrupt others when we're having conversation. We may, finish people's sentences or statements, or just intervene, in the middle of a conversation when inappropriate. We may have difficulty waiting our turn as well in different settings. For the DSM criteria for children, it does require uh, 6 or more of these symptoms in children, and slightly less, 5 or more in adults. So in order to meet the criteria for hyperactive impulsive presentation, um, the child would need to meet at least 6 of those symptoms, and the adult would need to meet at least 5 of those symptoms. On the inattention side, some of the symptoms here, again, nine symptoms: fails to give close attention, makes careless mistakes. So, rushing through homework, rushing through, tasks, not giving close attention to the details of those tasks, resulting in errors, mistakes, etc. Difficulty sustaining our attention. So, being able to, dedicate our attention over a period of time, sitting down for an hour or two, really, really putting a lot of intention into getting a task done that requires multiple steps, for instance. We have trouble in that area. Difficulty listening. So again, if you're in a conversation maybe, or if you're in a classroom setting and a teacher is teaching, we're having real trouble listening, following. Our mind is maybe wandering to different places, daydreaming, that kind of stuff. Difficulty following instructions, difficulty, attending to all the steps that are being told to us, losing track again of those instructions in our mind. Difficulty organizing tasks, knowing the different components of tasks, the different steps associated with tasks, getting our materials and things together in order to complete tasks. Um, there's often an avoidance or a dislike of tasks that require sustained effort. So we often see folks, maybe avoiding schoolwork, or not even attempting it because they dislike it so much. Again, remember, this is a disorder of motivation, regulating our emotion, and sometimes we need to do things that we don't like to do. But for folks with ADHD, that's really hard to sort of regulate their motivation around, particularly around tasks that they don't like to do. You may see that they really, have no problem or less problem doing things that they really like, because there's greater motivation there. Losing things for needed tasks, so losing backpacks, calculators, different tasks that are needed. Often distracted by extraneous stimuli. So sitting in a room and maybe noticing sounds outside in the hallway or outside the window, and just really getting sucked in by all of the things that are around us. Being forgetful in daily activities, forgetting to, attend appointments, forgetting to hand in homework, forgetting to, yeah, to take certain things to work or to school. Yeah, it's very, very common. So again, on this side, six or more of these symptoms need to be present for children. If they are going to be diagnosed with an inattentive presentation, five or more, slightly less again for the adults, five or more. So in terms of assessment and diagnostic updates for the most recent DSM-5, one of the main things is that you'll notice is that ADHD is now listed under a category called neurodevelopmental disorders. It in the previous version of the DSM-4, ADHD was classified under disorders usually first diagnosed in infancy, childhood, or adolescence. And this change has really been the result of this idea. I mean, we've had more and more research again coming out supporting that this is a neurodevelopmental disorder. There's lots of research, very clear research suggesting or confirming that this is a real biological neurogenetic disorder. And there's more and more research coming out that of how ADHD presents in adulthood. So the DSM committee decided that this would be a better place to put this disorder. So now there's some adult language included in the DSM, particularly around the thresholds. Six for children, five for adults. The age of onset has also been raised. So meaning that the symptoms need to manifest by this age. So in the latest version, it's been raised to 12 years. It was previously before 7 or by the age of 6. Folks would need to have demonstrated the symptoms that I just mentioned. Another important shift is that the DSM now allows autism spectrum disorder to be diagnosed with ADHD. In the previous versions of the DSM, that was not the case. You could not give both ADHD and autism disorder, spectrum disorder diagnoses. There's also some language shifts around in previous versions. The word subtype was used, and now presentations are used with this idea that ADHD. There's only one type of ADHD. ADHD is the disorder, but it can present in these three different ways. So we can see a predominantly hyperactive impulsive presentation. We can see a predominantly inattentive presentation, or we can see a combined presentation if those symptom thresholds are met in both of those domains. In terms of the cross-setting requirements, we do need to see the symptoms in multiple settings, right? So we wouldn't diagnose necessarily somebody with ADHD if they're only showing the symptoms um, at home, for instance, right? We want to see at least some of those symptoms occurring in other environments. We don't necessarily need to see them at the same level, right? And it's very common for folks to, maybe have less symptoms, let's say at school, compared to at home, or maybe the opposite way around. And that just, varies because of the structure of that environment, the accommodations that are present in the environment, et cetera, right? So we'll see variations in how these symptoms present in different settings, but we want to make sure that we're seeing some symptoms across settings. Um, and another thing related to the cross-setting requirement is that, in terms of assessment, we typically will administer multi-informant ratings, and that helps us to get that data. So, when I do ADHD testing, I'm administering to the parent, I'm administering to teachers, for instance. For adults, I'm administering to the adult, I'm administering to maybe a partner or a spouse. I may administer to somebody that the adult works with as well. Okay, and then another diagnostic point here is that symptoms cannot be, better explained by another disorder. So we just want to make sure that we're considering that some of the symptoms that we might see are the result of other conditions. And I'll talk about comorbidities in just a moment. All right, so there's been several critiques of the DSM-5 based upon more recent research. So first of all, a lot of people just don't like the name of the disorder, attention deficit, right? Because this is a condition. It's not really a deficit of attention. It's more of a difficulty regulating motivation, regulating, um, our impulsivity, regulating our behavior around these sorts of executive functioning skills. And ADHD uh, impacts many more executive functions than just inattention. So there's lots of executive functioning skills like planning, organization, working memory, emotional regulation, all of these things. And so a lot of people really don't like the language around the name of the disorder. So there's been some some uh, requests to maybe look at that. Uh, Also on the impulsivity side, you'll notice from the symptoms that I just went over that the DSM really focuses on verbal and motor impulsivity, but we know that the impulsivity is actually much broader. There's emotional impulsivity, there's cognitive impulsivity, and so the current DSM doesn't really adequately address that. Um, the wording in the DSM is still quite heavily child-based, and so as more and more research comes out about adults, that's going to be probably updated in the next version. Also, some criticism around so in order to receive the diagnosis is you have to have these symptoms present for a duration of at least 6 months, and there's some that feel that the 6 month duration is too short, particularly for preschoolers. And we know that you know children at that age are so they're rapidly developing, right? And so um, we want to make sure that we're not, over diagnosing ADHD in those very, very young children who haven't had adequate time to really develop. So some are suggesting that we should raise that for preschoolers, the duration to about 12 months. But again, that's not what the current DSM says. So some other critiques here is that adults may demonstrate fewer of the common symptoms. So symptom thresholds again have been lowered to 5 in this current version, but based upon the research on how ADHD presents in adulthood, researchers are suggesting that we should even consider lowering the threshold even more to maybe 3 or 4 symptoms. Age of onset, lots and lots of research suggesting that clients, parents we're not great reporters in terms of really, really knowing accurately when symptoms began. And so uh, some are really concerned that we may be missing folks that actually have ADHD if they give us an age of onset that is not within the current criteria. So research suggests that we sometimes can be up to 3 years off in terms of our uh, recall of symptom onset. Also, the thresholds are based primarily on ADHD, how ADHD presents in boys, particularly for younger kids. And so, um, for younger girls, for instance, ADHD may present in different ways. The symptom thresholds may look different. One of the ways that, as somebody who does ADHD assessments, I'm always looking at the data from this perspective is I always select measures that I can do a gender specific norm comparison on, right? So like the Connors 4, the brief scales, the Basque. These are scales that allow you to actually um, compare your client's performance to the gender specific norms. So if I'm testing a girl, I can run the reports, the data uh, through that gender specific norms, and that's a better way, a much more accurate way of deciding if somebody is actually meeting the criteria for the diagnosis. All right. So, comorbidities, regarding comorbidities, ADHD is a condition that is highly co-occurs with other conditions. These are just a list of some of the data, some of the studies, and depending upon the study you're looking at, you can see quite a lot of variation. But just to give you a sense here, autism spectrum disorder, those with ADHD, 59% co-occurrence. Learning disorders, 10 to 92% co-occurrence, quite a broad range there. But again, depending upon the study you're looking at, tic disorders, 55%, depressive disorders, 12 to 50%, bipolar disorder, 5 to 47%, anxiety, 5 to 35%, conduct disorder, 3.5 to 10, oppositional defiant, 30 to 50%. 60% to 100%, again, depending upon the study, of those with ADHD will exhibit one or more comorbid conditions, and approximately 50% meet the criteria for two or more comorbid disorders. So really the takeaway here as clinicians is that we really, really, really need to not only be focusing on the DSM criteria for ADHD when we're doing assessment, but also making sure that we are looking at the DSM criteria for all of these other conditions and making sure we're ruling those out. Yeah. Or, sometimes we're giving multiple diagnoses uh, uh, for those clients. So really, really inquire broadly about the symptoms that people are presenting about. All right. So ADHD symptoms and impairment. So symptoms, as I mentioned previously, occur on a continuum. Our ability to regulate attention, our ability to regulate our impulsivity. These are traits occurring within all humans. All humans have these traits, but we function differently on the continuum of these traits. In terms of DSM-5, there are specific specifiers of mild, moderate, and severe, right? So when we're giving a diagnosis, we're also giving these specifiers. Is this a mild um, version of the disorder, moderate, or more severe? For mild, we're looking at that if someone is meeting the basic criteria for the disorder and not really having too many more excessive symptoms than what is the minimum required for the disorder. And we're also seeing minor impairments in their lives. But for more moderate or severe versions of the disorder, we're seeing more symptoms than what's required for that minimum baseline thresholds to be met. And we're seeing much more severe impacts across different settings. All right. So as I started the talk off by mentioning the public health impact of ADHD, and this is an area that has so much research on it. I mean, we could probably do a whole talk just on this, right? The public health impact, the research on the public health impact of ADHD. Um, so there, I'm going to just sort of walk through some of the research on these domains. But in terms of that academic, that educational realm, we see those with ADHD, untreated ADHD. So that's a really important note here. Um, ADHD is a very treatable condition, but when untreated, we see these impacts in the educational setting, poor school performance, disruptive behavior in class. We have more frequent risk of suspensions. We have lower educational attainment, less college attendance, lower graduation rates, and the list goes on and on. In terms of the more health domains, sorry, more interpersonal or social domains, we see, disruptions in family functioning. We have poor peer relationships, so difficulty in friendships. We have more risk for being victimized interpersonally. We have greater risk of arrests, um, poor intimate relationships. There's some research on marital couples where one spouse has ADHD. Greater risk for for separation, et cetera, et cetera. So quite a extensive body of research there. On the health side, I mean, there's pages and pages of research here, but more poor general health conditions, uh, poor nutritional eating pathologies, overeating, binging, higher risks of obesity, higher risks of type 2 diabetes, poor dental hygiene, greater risk for substance use or abuse, greater sleep problems, riskier sexual behavior, more STDs, higher risk for coronary heart disease, greater risk of early mortality and shortened life expectancy. So again, with untreated ADHD, there's data to suggest that life expectancy is reduced by up to 7 years. That's sort of a figure that gets um, talked about in the research quite a bit. On the financial side, difficulty with money management, uh, impulsive spending, lower credit card ratings, yeah, more likely to live with parents, etc. On the work side, you know, uh, greater levels of part-time work versus full-time work, less progress in career, more job changes, more frequently fired or dismissed, lower annual salaries, et cetera, et cetera. Um, on the driving side, more distracted driving, accidents, more crashes, uh, more frequent license suspensions. So you can see, I mean, I can speak all day about the data here, but you can see that when untreated, the impact can be really, really devastating for folks in so many domains of their lives. So it really is a public health condition that requires attention, that requires a treatment. But again, positive is that it's such a treatable condition. All right, so let's talk a little bit about the causes, the etiologies here. ADHD emerges from various causes, but all of them are biological. All of them are sort of this neurogenetic, neurodevelopmental in nature. Lots and lots of data around the genetic transmission, heritability rates. For example, in identical twins, approximately 80% share the condition. If you're sort of a non-twin sibling, about 30%. If you're a parent, don't have that data point on here, but if you're a parent with ADHD, it's likely approximately 40 to 60% chance that your child, your biological child, will have ADHD. Um, Lots of data and research that confirms that ADHD is not caused by social factors. So, not caused by parenting style, not caused by digital media use, not caused by psychosocial trauma, sometimes with like head injuries and those sorts of traumas, yes. But ADHD is not caused by social factors. So that's really important to remember because there's a lot of stigma, a lot of myths around these things in the broader culture. Approximately two-thirds of ADHD cases are genetic in nature, and approximately a third of cases are acquired. And the vast majority of acquired cases occur prenatally, so before birth. And I'll talk about some of those causes in just a moment. Um, Exposure to various environmental toxins can also impact gene expression. So this is a field called epigenetics, meaning that when we're exposed to certain environmental conditions, those conditions can turn on and turn off the gene expression. So it doesn't really change your genetic code per se, but it does turn on or off the functioning of those genes. So for those that might be carrying those genes associated with ADHD and have exposures to certain things, um, they may turn on those genes. But the takeaway here, though, is that the common pathway, despite these multiple etiologies, these multiple causes, the common pathway is that all of these causes impact the frontal cerebral executive network in our brain. Um, so that is the common underlying pathway that is impacted. All right. So prenatally, what are some of the conditions that play a role here? And there are probably some other ones that are not on this list, so I don't want you to take this as an exhaustive list, but these are some of the ones that are very frequently referenced in the literature. So alcohol use, very widely established that if a mother is using alcohol prenatally, the more alcohol she uses, the greater the risk for ADHD. Um, we also see that exposure to sort of these industrial environmental toxins like PCBs, hexachlorobenzenes, um, prenatally can increase the risk for ADHD. Uh, Glucocorticoids, these are medications that are used to treat autoimmune and inflammatory disorders, uh, medications like prednisone and these sorts of things. Sometimes, uh, moms are taking these to treat very real and very serious medical conditions. But there's been some evidence that consistent use throughout pregnancy can increase the risk for ADHD. And so, it's often a balance. You need to work with your medical team to sort of weigh the pros, the cons, the risks, the potential benefits to both mom and child in those sorts of situations. Premature birth, small size at birth, particularly premature births, babies that require sort of that sort of neonatal intensive care sort of interventions, sometimes can have these like small brain bleeds, and those sorts of cases seem to be at higher risk for developing ADHD. Pregnancy and delivery complications of all kinds have been shown to also increase the risk of ADHD. Some of the items here on the bottom of the list, maternal stress, poor maternal diet, maternal hypertension, maternal nicotine use, these have also been shown to increase the risk for ADHD, but the data is still out on whether these are causal factors or whether or not these are more markers for maternal ADHD. Because, if you have ADHD as a mom, you're gonna have more stress. You're gonna perhaps have poor nutritional diet. You're going to have conditions like hypertension, perhaps due to obesity or sort of those weight issues. You're gonna smoke more. So that ADHD increases the risk for all of those things. So the data is still out. More research is needed on whether these are causal or just indicates that maybe mom actually has ADHD and it's more of a genetic transmission in that case. Postnatal, so after birth, the etiologies, causes, we do see increased risk for ADHD with early exposure to lead poisoning. We see increased risk with certain infections, particularly infections that trigger an autoimmune response that attack certain brain structures like the basal ganglia. We see in pediatric leukemia cases, for instance, like exposure to radiation and chemotherapy can increase the risk for ADHD. Head injuries of all kinds, traumatic brain injuries, having a tumor in the brain, seizures, those sorts of things can also increase the risk. There's a medical condition called phenylketonuria, which is a toxic accumulation. So the body cannot process and metabolize phenylalanine. And so that buildup of that particular compound is also associated with increased risk for ADHD. So clearly you can see from the causes that I've gone over, the etiologies, you can see that ADHD is quite clearly a biological, a neurobiological, a neurodevelopmental uh, disorder. It's not a disorder that's caused by social factors. Okay. So let's talk a little bit more about the brain's executive reward system because that's really um, the primary structure, the primary system that's involved in this disorder. And just to start us out, this is just a diagram of kind of the normal trajectory of development with regards to our executive functioning system. And you can see that it takes quite a while for that system uh, to really finish developing. So that's another part of this in terms of psychoeducation when I work with clients and parents and teachers, et cetera, is to remind folks that, the executive functioning system is really developing really way into early adulthood. So, we should in all children, we should not expect the systems to be fully on board, particularly earlier in childhood. But this kind of gives you just a general sense of the normal trajectory here as children move from early childhood into middle school, into adolescence, and then into early adulthood. I'm not going to dive too deeply in here, but um, you'll be able to see this when you get the slides. Okay. So, in terms of the structures that are implicated here in this executive network, there are lots and lots of structures that are associated with this system. The main one being kind of that prefrontal cortex, and so that in this diagram here, it's kind of represented in more of that red area, the frontal lobe area. This part of the brain is really involved in higher order cognitive functions, working memory, uh, risk processing, planning, organization, decision making, social behavior, regulating social behavior, those sorts of things. Um, we also have the basal ganglia, and basal ganglia I kind of put up there in the corner and have an arrow going right to the middle of the brain. It's a structure that's deep in the middle of the brain, and it's associated with a variety of functions, including regulating voluntary motor movements, procedural learning, conditional learning, eye movements, cognitions, and emotions. Um, so that's another part of the brain that's really implicated in ADHD. The cerebellum is another area, and the cerebellum is represented here in the blue area and really plays a very important role in motor regulation, coordination, um, and you know, all of these structures are connected via a network of neurons, right? And so all these brain areas are communicating with one another in service of our executive functioning system. Another area that's not really represented here is called the corpus callosum. And this is the bundle of fibers in the middle of the brain again that connects the two hemispheres. So it facilitates communication between those two hemispheres, the two sides of the brain. And so these are areas that are impacted by ADHD. So what do we see from neuroimaging studies, and many, many, many neuroimaging studies now we have? We see that the areas that I just mentioned are often smaller in volume and also have variable and reduced activity, right? So we can't often, we might not be able to rely on sort of that consistent functioning, consistent firing, uh, consistent communication between regions. So we see a very clear difference with folks with ADHD and those that don't have the condition. We also see that this then results in about a 2 to 3 year developmental lag. And, just, anecdotally from, practicing, many parents come in and they say, I have this 17-year-old or this 10-year-old, and they just seem like way younger than they should. When my other kids were their age, they were much more advanced, right? So you often see about a 2 to 3 year developmental lag in the growth of those areas, the functionings of those areas. But again, the most uh, the most prevalent part of the brain that's impacted is that prefrontal network. The frontal lobe is what's most consistently impacted in ADHD. All right. Um, So, as therapists, as parents, as caregivers, as teachers, we are often, you know, for all of our kids, we're often functioning as sort of surrogate frontal lobes for our children. But, in particular for situations where we have a child or we're working with a child with ADHD, we have to sort of be mindful of um, our extra our extra responsibility in helping our kids with those sorts of executive functioning skills. All right, it is about 10 o'clock, so it's actually perfect timing for a brief break. Um,
Hi there. Yes, sorry. It took me a minute to come off of mute. So why don't we do this? Why don't we just take a couple quick questions first, and then we'll
sure.
have a nice break. And as I suspected, we're getting some really beefy questions, so it's going to be hard, Dr. Morrison, I know, to like give brief answers. Um, One person asked, was the comorbidity section functioned on children or focused on children? I think they're referring to your slide with the comorbidity rate.
Yeah.
This person said, I'm wondering about substance use disorder and ADHD and other comorbidities for adults.
Yes, the slide was sort of a combined across the lifespan, and it's not an exhaustive list. So yes, you're right. There are other comorbidities like the substance use and those sorts of things, but that was just meant to kind of give you a taste, a flavor for some of the comorbidities that are seen. I do have a couple of references in the actual presentation that talk specifically about comorbidities and substance use and those sorts of things. So when you receive the packet, you'll be able to kind of dive a little bit more in. But you're very right. There are some other conditions that also co-occur there.
Okay, terrific, thanks. On to the next one. How about, Judy asks, how about auditory processing as a comorbid for ADHD? So a child may appear to not be listening or attending because of
Hmm.
fidgeting, but may actually not be hearing accurately. What about that?
Um, yeah, I mean, definitely there might be reasons to have somebody evaluated by, an audiologist or some to kind of rule out some of those other neuro developmental disorders as well. Absolutely. Good point.
Okay, thank you.
Oops.
Laura asks, I understand that social factors do not cause ADHD, but can't they impact brain development and presentation if there are genetic predispositions? I have a hard time reconciling this with anecdotal data that suggests digital media use and its impact on motivation and reward.
Yeah, absolutely. Yes, there is data that suggests that environmental factors can uh, impact our brain development. But in terms of causing a condition like ADHD, there's no evidence that those things, digital media use, cause ADHD.
Got it. Thank you. Tracy asks, I've been told by another clinician that sometimes ADHD can be a misdiagnosis for symptoms that are actually trauma-based. What is your perspective on this?
Absolutely. Definitely, we sometimes see the same symptoms or similar symptoms in folks with different types of trauma. So that's again underscoring my point about really, inquiring broadly about, symptoms and about histories and about potential causal factors.
Got it. Jamie asks, what is the comorbidity and relationship between antisocial personality disorder and ADHD?
That's a great question. I actually do not know the answer specifically to that question.
You don't know everything.
I don't know everything.
Well, for Jamie and anyone else, Dr. Morrison, we're going to share Dr. Morrison's contact information. So perhaps you could communicate afterwards with that, or we could look it up. Thanks for the question. Another one, someone asked, can a person outgrow ADHD?
Mm. Um, Not to my knowledge, based upon the research that I've read. It is a condition that is not curable. It is something that people can learn to live with and manage. And with treatment, for instance, may not be as impacted by the condition, but to my knowledge, there's no evidence that people really grow out of it. It
Got
might
it.
it might present in different ways throughout one's lifespan,
Mhm.
but yeah.
Okay. One more question, and it's mine. So,
Okay. Yeah.
uh, I have noticed, professionally and personally, there seems to be a lot of dogma around
Mhm.
ADHD
Yeah.
among both lay people and professionals. As in, everybody's a little ADHD, as in, it's
Mm.
overdiagnosed, as in, we're overusing medication. How can we combat that dogma since, I was just gobsmacked by the data point you shared that fewer than 10% of people with ADHD get treated.
Hmm.
That's terrible. That's a terrible number,
Yeah.
since it's so treatable, right? What
Absolutely.
can we do to combat dogma so that we can have more accurate and timely diagnoses?
Yeah, I mean, I think that a lot, I mean, I think the public health impacts of the disorder are so significant and they're so well researched.
Yeah.
So really raising awareness
Mhm.
about that in whatever spheres we are involved in is so important.
Mhm.
Um, and the neurodevelopmental research is so clear
Mhm.
that this is a real condition. And yes, most of us have these symptoms to some degree, right? But in order to truly meet the criteria for this disorder, it's a much more rigorous process. So, I think people are sort of self-diagnosing and things like that on, based upon what they see on social media now and all sorts of things in our culture. But it is a very real condition with very real impact. So I think just raising awareness about that is super important.
Well, thank you for educating us
Yeah.
today with this. And so let's take our break. Thank you so much. It is 10:06. Why don't we plan to meet back here at 10:15? We'll give us a 9-minute break. How about that?
Good.
And we'll go from there. All right, everybody.
Great.
Thanks. Started.
All right, welcome back, everybody. We're going to move into more of the support side of things, treatment and supports for folks with ADHD. I want to kind of go over some core concepts for support that are widely supported in the research. One is the importance of psychoeducation, and psychoeducation alone can really produce significant impacts for folks. Uh, the idea that with understanding, we increase compassion, we increase empathy, we increase our ability to advocate, we reduce the guilt, the shame, the anxiety we may feel around these sorts of symptoms. Early intervention is another really important factor in the research. So the sooner we intervene around uh, these issues, these symptoms, the better the outcomes, better the public health outcomes. So we don't want to ignore, we don't want to put off getting treatment for these sorts of conditions because they can have real significant impacts in so many areas of our life. I will be talking a little bit about medication in just a moment, but there's possible even neuroprotective factors or neuroprotective effect of starting medication early. So we can see that sometimes medication can, particularly stimulant medication, can help with uh, regulating or the functioning or normalizing some of the structural impacts of the disorder if started sooner. I'll dive a little bit more into that in a moment. Taking a harm reduction approach. So understanding that ADHD cannot be cured. There's no cure for ADHD that I'm aware of, but can be managed. And just a reminder that ADHD is a performance disorder and not a knowledge disorder. So it's not that folks do not know how to pay attention or do not have skills around certain um, executive functioning abilities, but it's just that they have difficulty showing that knowledge or that skills. And so we need to help folks show what they know. All right, so let's start with medications. Um, so really, like the gold standard of ADHD treatment is stimulant medication. There's so much research on stimulant medications. It's by far the most effective treatment for ADHD. There are two classes of stimulant medications. There's the amphetamine salts, and then there's methylphenidate. There's a couple versions. There's an immediate release, which is shorter acting, and then an extended release, which is longer acting. Um, Methylphenidate tends to be on the shorter in terms of that immediate release, maybe 3 to 5 hours, 3 to 6 hours. Um, Amphetamine salts last a bit longer, maybe up to eight hours. So there's some differences there, but on the non-stimulant side, there are two classes. There's selective neuroepinephrine reuptake inhibitors and alpha-2 adrenergic agonists. Um, in terms of the stimulant medications, I should mention that the primary mode of action is to increase the availability of certain neurotransmitters in the brain, particularly dopamine and norepinephrine. So these medications typically will help to boost the availability of those two neurotransmitters um, in the brain. Stimulant medications are classified as a controlled substance. And so that's an important factor. So there's sometimes some barriers around getting prescriptions or those sorts of things. But stimulant medication results in symptom improvements approximately 70 to 90% of the time. Okay, so it may not eliminate all the symptoms, but patients with ADHD who take stimulant medications report symptom improvements up to 90% of the time. So that's a pretty effective, um, response rate. Um, there's some myths in the general culture that stimulant medications are addictive or cause an increase likelihood that one will develop substance use disorders. That is not supported in the research. In fact, it's the opposite. So when taking your medications, your stimulant medications as prescribed, um, there is less chance of developing addiction disorders of all kinds. Okay. Sometimes the non-stimulant versions of the medications are preferred because folks may have side effects to the stimulant medication, such as headaches or reduced appetite. Or, sometimes we've seen some difficulty with supply of the stimulant medication. So sometimes folks will opt to go the non-stimulant route too. Or sometimes there's, other comorbidities that are at play. And so, psychiatrists or doctors might make those decisions to try the non-stimulant medications. But by far, the stimulant medications are the most effective. Okay. There seem to be some neuroprotective effects of taking stimulant medications. So we see that taking stimulant medications can improve the functioning of those different brain areas and those brain connections that I mentioned earlier. And there's been some interesting research more recently with older adults with ADHD who are taking stimulant medications. Typically, in the normal process of aging, our brain volume, the structure of our different parts of our brains shrink. And there's been some evidence that older adults who've been taking stimulant medications to treat their ADHD show a reduction in the uh, in the volume. Sorry, show a less reduced shrinkage of those brain structures. So they don't show as much shrinkage um, as one would expect in later adulthood. So seems to be some protective uh, effects there of taking stimulant medications. So why would we do therapy if stimulant medications are so effective? Well, there's several reasons to combine them. The research shows that medication adherence is an issue. So sometimes people are not really great at taking medications regularly. They miss medications. Medications only work for certain periods of the day, right? So you need other skills, et cetera, to manage the symptoms. Also mentioned the host of comorbidities that can be seen. So combined therapy can also address some of those issues. Research shows that when we pair therapy and medication for ADHD, there's an enhanced effectiveness of the treatments. So, even though the effectiveness of stimulants alone are 70 to 90% effective, right? It can boost adding therapy can boost the effectiveness about 10 to 15 additional percentages. There's some research suggesting that when you're doing both medication and therapy, you may actually not need as high a dosage of the medications. And then, of course, therapy also enhances sort of the environmental, the parenting skills, the scaffolding, the empathy, the advocacy, the understanding that has been also shown to be so useful in managing these sorts of symptoms. Um, So when we talk about therapy, I mean, really need to underscore the power of psychoeducation. So, like clinical researcher Russell Barkley, for instance, he developed a program called Defiant Children. In his research, for example, the most significant change occurred after the psychoeducational component of the program. So, a lot of these programs have modules. So there's like a psychoeducational uh, module that usually is the sort of start of the program, and then there's more of a behavioral component where we're teaching sort of um, antecedent-based techniques and consequence-based techniques like selective ignoring, praise, reinforcement, etc. His research, as many other clinical researchers in this area, have shown that the vast majority of the improvements actually occur after the psychoeducation phase. So just educating, understanding, raising awareness, shifting our mindset between, from, this is a bad kid, or this kid is lazy, or I'm having those sort of internalized negative ideas and beliefs about oneself and others, shifting that to a better understanding of what's actually happening can create profound impacts. Um, in the therapy world, particularly with children, there's a very strong parenting training component that's often present. Uh, and I just sort of reviewed some of the components of the parenting sessions, but what the research is showing is that those parent management uh, techniques are really more effective for kids that are lower than the age of 12. After age 12, those strategies seem to lose their effectiveness. They still do create some improvements, but not as significantly as if your client is a young school-aged child. So, for instance, some of the research on Russell Barkley's uh, um, work suggests that parenting training can result in symptom improvements 60 to 75% of the time for under the age of 12. And then over the age of 12, we see that effectiveness goes down to about 25%. So still offering some improvements, but it's much harder to create change in the way that we want to with teens and adults. So what do we do then for teens and adults? Models that focus on CBT, cognitive behavioral therapy for ADHD and executive functioning. Um, some of the researchers there are Salanto and Safran. These seem to be more effective for older kids and adults. And the focus here is, again, providing a lot of psychoeducation around the disorder, uh, reframing how one views their disorder and their symptoms. So instead of internalizing those negative self-talk, we're looking at it as a true neurogenetic condition. Then we're kind of teaching folks how to improve their time awareness, how to reduce distractibility, how to address procrastination, how to plan, really implementing a whole host of executive functioning skills, sort of coping with these sorts of day-to-day activities that come up in situations that come up. We're also, doing some cognitive restructuring work around, how to shift mindset, how to look at different situations from a different vantage point, how to, let's say, sort of like maybe envision your future self. There's so in ADHD, we're so kind of sucked into the present moment. We get so kind of caught up in what's happening in the here and now. We sometimes forget about what are the consequences? What do I want to see in the future, right? So kind of doing some cognitive restructuring around those sorts of concepts. There's another model that's been shown in the research to be really effective, the parent friendship coaching model. This is interesting. Social skills are often, as I mentioned before, one of those domains, the social realm, the peer realm that often struggle with, kids who have ADHD. McCamey developed this parent friendship coaching model where the therapist or the clinician is teaching the parent or the caregiver how to coach their child in navigating social situations. So it's really helping parents remind their kids about how to effectively use their social skills. It's not necessarily about teaching social skills, it's about reminding them and creating environments that help them to most effectively utilize their social skills. Remember that ADHD is not really about not knowing social skills. It's about how they they have difficulty showing those skills, right? So the coaching approach seems to be an approach that has been shown to be effective. An important thing about social skills groups, I've seen so many folks offering social skills groups for ADHD over the years. It's really important to remember that we don't want to put kids in situations where it's just going to exacerbate the shame or the lower self-esteem that often comes with ADHD. So if you sort of put a child in a group that, without the real coaching, without this really coming from this place of like, it's not that they don't know the social skills, it's that they don't know how to demonstrate them or regulate them. That's the issue. So if you sort of take a different philosophy in those groups, you sort of avoid exacerbating the shame and the problematic self-esteem that's often seen in these conditions. All right. So some of the other points of support that has been shown in the research, movement of all kinds has been really effective. So, integrating exercise, movement through at least 3 to 5 times per week. Thinking also about macro and micro movement. So, in addition to formal sports and exercise, also fidgets, use of fidgets, can help regulate, you know, um, some of these symptoms. Using standing desks, for instance, if you're at work or school, being outdoors and in nature, moving, hiking, walking can really help. Sleep can improve our ability to use our attention effectively. Again, it doesn't um, eliminate the disorder of ADHD, but it can help um, more effectively use those skills. As clinicians, we need to be kind of assessing what's getting in the way of that. So is it that the bedtime routine is just not not consistent, or there's not consistent parenting around sleep, or is there a medical condition going on, like a breathing disorder or like a sleep disorder, and of course referring to a medical professional to get that looked at. Um, Nutrition. This is an area that more research is needed. That's sort of my takeaway from reading lots and lots of articles on nutrition. There's some evidence that like food additives and artificial food coloring can increase symptoms like hyperactivity. Um, but again, the research isn't like super robust. It's not as robust as some of the other pieces of research I've talked about, like the neuroimaging and those sorts of things. There's some evidence, there's some promising evidence about like minerals, like magnesium, vitamins, probiotic, like the gut brain connection. But again, that's still in development, I would say. Let's see. Mindfulness, martial arts, and yoga. There's some good research on mindfulness based techniques as improving particularly our ability to regulate attention, our ability to increase self-awareness. So being aware of our thoughts, slowing down, being aware of our emotions, being aware of our physical bodies. And that, of course, can help us, uh, regulate those different aspects of our functioning, whether it be our attention or our um, impulsivity. Focus on breath work, visualization has been shown to help in this area as well. There's a model called mindfulness-based cognitive therapy, which has also been shown to be very promising in this area. Again, it's not just teaching meditation skills, but it's also adding in that cognitive piece. And again, that's mostly shown to be more effective for the older kids and adults. Martial arts, again, increases our self-awareness, our body, our spatial awareness, our emotional awareness, our impulse control, our physicality. That has been shown to be effective. Um, Yoga, ADHD symptom reductions and improved executive functioning. So there's been some research there that has been promising. So these are areas that have some research base, but again, not as extensive, not as extensively researched and not as extensively supported as like the medications and some of the therapy models. Okay. On the academic side, we have classroom management. So this is similar to kind of that parent management approaches that I've mentioned before, where we're maybe teaching teachers how to how to intervene, how to, reinforce behaviors, how to sort of scaffold the environment, et cetera, so that kids have greater success. The important thing here about classroom management is that you really need to intervene in the moment. So when the child or teen is actually doing the task at hand, it's really important to be, intervening there. We're wanting to use antecedent-based and consequence-based techniques. So antecedent-based, again, really meaning that we want to prepare the environment so that that child is most likely to be effective in that task. So whether that be seating in a different location, the physical arrangement of the classroom, being mindful of like who that person is sitting next to, the level of noise, et cetera, et cetera. And then consequence-based techniques are more of those reinforcement based techniques. So selective ignoring, so ignoring behaviors that you're not really targeting, and focusing on whenever a child is doing the things that you want them to do, like maybe they're sitting down quietly, or they're they've pulled out their homework and they're ready to work. Um, at that very moment, that is a chance to really reinforce that from a positive perspective, point that out, give that praise, reinforce that motivation, that inner motivation that that child is demonstrating in that moment. Um, so the research here really is suggesting that teachers really need to be very consistent about using these skills in order for it to translate into positive academic and behavioral outcomes. Uh, Accommodation. So lots and lots, of course, whenever I do assessments, I mean that's really a main piece here in the academic environment that I'm recommending. Physical location, arrangements, lesson presentation, note-taking supports, presenting learning material in multiple ways, verbally, experientially, you know, use of recording, so allowing the child or student to record the class lectures, for instance, and then re-listen to them later in the day or week. Um, Assignments, having extra time on assignments, allowing kids to demonstrate their knowledge in other modalities, just besides writing or besides tests. Test taking, extra time on those, taking the tests in other low stimuli environment. Again, offering the student other ways to demonstrate what they know. Okay. So for adults and more work settings, again, with any of this, we really want to take a moment to try to define what the problem is. Is it motivation? Is it awareness? Is it both? And then that allows us to make the most effective interventions. We want to make sure we're addressing vulnerabilities. Are people sleep deprived? Are people eating nutritiously or getting exercise? So making sure that the underlying vulnerabilities are taken care of. Um, Reflecting on when is your most productive time of the day or the week, Um, so that requires a little bit of like introspection. When do I notice my attention span being the most effective? Like, is it mornings? Is it mid-afternoon? Is it in the evenings? And really protecting those most productive times for your most important work projects. Prioritizing, setting and prioritizing goals. So getting people really in touch with like, why is this task important for you? Like, why is it that you want to do this task? Why is this important that you do this task, right? So getting people connected to the reasons, their values, their future outcomes. With ADHD, there's sort of impulsivity around that verbal impulsivity, so sometimes people just, they are asked to do something and then they just say yes without really stopping and thinking. So encouraging our clients to really slow down, pause before, committing to something. Is it something that they can really take on or achieve or want to do? Uh, Using a scheduling system of various kinds, whatever works for you. Temporal discounting, I kind of, referenced that earlier, but just, with ADHD, you're so kind of sucked into the moment, right? Into the present. So distracted and drawn in by what's happening in the immediate. And so we forget about our future selves, about what we want in the future. So teaching clients about that, bringing in more reflection about their future self. What do they want? Um, Being aware of tasks, so greater awareness of like, okay, these are certain tasks that I just get so sucked into, or these are tasks that I feel a bit slippery with. I often slide off or get easily distracted. So bringing some awareness with that, and then you can sort of do some planning and scaffolding around those different areas. Practice self-compassion, again, take some empathy that this is a real condition that you have. It's a medical condition. It's a neurodevelopmental condition, and just like diabetes or asthma or any of these other conditions, there are some limitations and there are some uh, ways in which we need to manage um, those conditions and symptoms. All right. So strategies for that I find have found useful and have been supported in the research as well around supporting inhibition. So use of visual cues, stop signs, hand signals, pictures of a quiet mouth, traffic lights. These are some things that might be really effective in like or more useful in like a classroom setting, for instance. But you can certainly do this at home too. Um, uh, Fidget toys or objects, Velcro, squishy balls, therapy putty. Adding a step to tasks can sometimes slow things down, slow thinking down, slows behavior down. So when a child begins to interrupt, for instance, in a conversation, maybe prompt them to write down their comments or questions instead of verbalizing them. So it just adds that layer of slowing down and instead of impulsively acting. Some strategies for sustained attention. We uh, can shorten the length of tasks and then gradually extend, so there's a method called the Pomodoro method, which uh, you take a task and you break it down into no more than four 25-minute chunks of time in a row separated by 5-minute breaks. So you do need to kind of get a timer of some sort and really be fairly structured about that. Give yourself 25 minutes of sustained work, take a 5-minute break, step outside, get a glass of water, and then come back for another 25-minute chunk. Um, the use of visual timers, modeling, coaching, reinforcing, thinking out loud procedural steps. Sometimes we need to teach social scripts. So teaching our kids or even our adults how to advocate. I need a little bit more time on this particular project. Can I have more time? Or can you come back to me when I'm feeling more ready to answer that question? Or can you show me an example of uh, what you're asking me to do? Okay, so for task initiation, so just getting started, some strategies there. Again, target motivation. And sometimes we need to incentivize and reinforce any amount of effort. So that's that positive reinforcement technique. So if you're working with a child who just will not do their homework at all. So we're going to just really, really start with very micro moments here. So even just sitting down and getting your backpack, might be a place to start. And, really reinforcing that and then expanding upon that. Teaching self-advocacy skills. Can you help me to get started is an important piece. Scaffolding, breaking things down into smaller steps. We've talked about that. Developing a work checklist. So well before you even sit down to do your work, have a general framework, a general checklist of things that you need in order to even start that project. So gathering your materials, sitting at desk, maybe have this kind of posted somewhere in a child's room, or if you're an adult in your work environment, like what are the things that I need in order to be most effective in this moment? And of course, we're going to be reinforcing, pointing out, praising along the way as much as we can. We really want to highlight the motivational piece, that inner motivational piece. All right. So, planning. strategies for planning, daily visual schedule, so posting a daily schedule of some kind, start and finish time, name of activity, task, review the daily schedule, have a conversation each morning. If you're a parent, sitting down with your child, having a conversation about that, returning from school, having weekly or monthly calendars, posting that as well. Uh, Sort of that big picture that sometimes can be hard for folks with ADHD, is that big holding all of the pieces in their consciousness. So having an external calendar with all the things, all the upcoming due dates, um, maybe writing some progress steps along the month, so by this date, I want to get this part done. By this date, I want to get this part done. And again, this can be done in collaboration with a parent, with a therapist, with a teacher, so that uh, that individual gets support um, around putting that plan together. Uh, Important note about school planners: we want to avoid planners that have a lot of visual clutter, quotes, distractions. Some of these planners are quite are quite elaborate. So keep it simple. Mhm. All right, some strategies around flexibility. So using social stories, real life scenarios to help brainstorm solutions, discuss different possible outcomes or coping strategies to different situations. Use of logic games, strategy games can help promote, flexibility if we kind of mix up the rules and try doing the games from a different vantage point. Prompting thought stopping, relaxation, coping strategies, taking deep breaths, calming, self-talk, leaving the situation until calm, modeling flexibility when encountering roadblocks. Some strategies for organization. Oops, sorry, went too quickly there. So organize with your child or client, posting a picture or a visual cue of some sort of an organized locker room, or an organized, locker, or an organized bedroom, for instance. Yeah, it just provides that visual reminder of like what are we trying to sort of accomplish here? What is an organized locker look like? What does an organized room look like? These are things to remember. This is to remember to place objects in this location or in this manner. Schedule a weekly time to organize our backpacks or our rooms, and again, it often needs to be a relational process, right? So we may not be able to just sort of send our child off and give them this task and then expect everything to be the way that we want. We may need to actually schedule time where we can do some of this together, and you're modeling and coaching and reminding kids how to effectively use those skills. Binders, color coding, labels, checklists, steps, feedback, reflection, positive reinforcement. Again, all things that are useful. Strategies for self-monitoring. I know in an academic environment, many schools use these sort of uh, dashboards where you can kind of look at grades, where you can look at upcoming assignments, etc. Sitting down once a week and reviewing that together. Um, Inquiring about upcoming assignments. What's the plan on sort of getting things done? Breaking things down into smaller tasks can be really useful. On the emotion side, emotion checklists, the facial recognition, facial cues, those feelings charts can be really useful in helping kids, particularly younger kids, identify their feelings um, and let you know and let themselves know how intensely they're feeling certain things. Strategies for memory, uh, lots of strategies here that have been effective: highlighting, use of sticky notes, underlying flashcards. So you're needing to teach some of these skills, using multisensory input as a way to integrate the material, repetition, 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 simplifying language, chunking things down, the use of mnemonic devices. So teaching how to associate information we want to remember with an image or a sentence or a word or a location, that will help with easy recall. On the emotional regulation side, you know, uh, prompting to identify emotions, talking about, watching movies together, the facial expressions, reflecting on body language, all of those sorts of things, find opportunities to talk about different emotions as they come up throughout the day, model appropriate expression, work with an individual to identify how their body feels with different emotions and feelings, identify triggers, teach coping skills. So we've touched on some of these things in other parts of the presentation, but so play is also really extensively researched. The benefits of play is that and this is not only for kids, but also adults. Play is intrinsically interesting to us. It's intrinsically motivating to us. So whenever possible, building in play to our learning, to our work, to our interpersonal relationships. This can also lead to improvements or reductions in some of the symptoms I've talked about. Okay, so we are kind of coming up on the end here. So just to wrap us up, I want to just summarize some of the conclusions and takeaways that I'm hoping you're all leaving with here today. But ADHD is a well-established disorder that has really serious public health consequences. And we really need to emphasize early intervention. The earlier we intervene, the better those outcomes are. ADHD is a highly treatable disorder. ADHD is a disorder of performance and motivation and not knowledge. ADHD medications are very effective, particularly the stimulants, and very safe, and may provide some long-term protections or enhancements to our brain if we have ADHD. Medication plus psychosocial supports are even more effective when combined. And psychoeducation is incredibly important and can really increase our compassion, our empathy, our advocacy, and our support for those with ADHD. So those are some of the main takeaways I hope you're leaving with today. It really has been a pleasure speaking with you, and I do have ways to connect with me if you want to connect with me on LinkedIn or send me an email or ask a question, or um, feel free to reach out.
Wonderful. Thank you so much, Dr. Morrison. We do have a few questions. So here's what I'm thinking we'll do. Since we're coming up close to the end time, I'm going to go over the housekeeping stuff now about CEUs, and
Sure,
then we'll get to the questions if that's all right.
that's fine.
I just want to thank everybody who logged on today to be with us. We hope you found this webinar as compelling and as formative as I know I did. As someone who has a close loved one with this disorder, I just was like glued to my screen the whole time. So thank you so much for spreading the facts out into the world. Um, I'd like to invite everyone to please see the links in the chat that Melissa is dropping in there for you, both to the evaluation and the post-test, both of which must be filled out in order to get CEUs. You'll also receive an email later today with those same links. The evaluation and the post-test will close in 1 week, next Friday on August 15th, and there will unfortunately be no exceptions and no extensions to this requirement. So please feel free to get in touch with the organizers via Eventbrite if you have CEU questions. Okay, so now we can move on to the questions. Let's see, I've got them in a few places here. Someone asked, can ADHD in adulthood impact judgment and responsibility in professional settings? And I know you went over some of the
Hmm.
workplace issues, so you
Yes.
kind of got into some of it, but
Yes, yes, it can. Yes. So, we often see, um, you know, coworkers, for instance, who maybe don't know that somebody has ADHD, like judging those behaviors or those symptoms sort of negatively, sort of, and that can impact, yeah, it could impact the work environment for sure. And on the individual side with ADHD too, it can impact self-judgment, self-esteem, the way that people feel in terms of their functioning in a work environment. Absolutely.
Yeah, thank you. One person noted in the chat that they have a lot of parents who tell them that their children with ADHD have trouble falling and staying asleep. Do you have any
Hmm.
thoughts or advice about that?
Yes. So there's research to suggest that folks with ADHD do have uh, difficulty with increased difficulty with sleep. So you want to be sort of trying to kind of assess that a little further by understanding what's happening around the bedtime routines, making sure that things are pretty consistent, teaching sleep hygiene. Uh, but you may be missing something. It could be something medical going on. It could, uh, you know, making sure to make those referrals to their primary care physicians to get checked out. Maybe there is something from a sleep disorder perspective happening. But as a therapist, really doing a broad inquiry and then um, teaching good sleep hygiene, teaching the importance of consistency. Are the kids bringing devices to bed? Like all these sorts of things can really impact sleep. So doing a deep
Right.
dive.
Gotcha. Another person asked, with an 18-year-old diagnosed with ADHD at an early age, on
Mhm.
medication and engaged in therapy, can the use of CBT combined with SFBT or solution-focused brief therapy be used to address this client's disorder in a positive manner?
I wouldn't see why not. Absolutely. Yeah.
Right. Katie asks, what is your approach and is there a differential diagnosis for people who present with inattention or motivational difficulties that appear to be more rooted in their relationship to technology than in ADHD?
Can you repeat that question?
Yeah. What is your approach and is there a differential diagnosis for people who present with inattention, motivational difficulties that appear to be more rooted in their relationship to tech than rooted in ADHD?
Hmm. That's a really interesting question. Yeah, I mean, I think I might, around the comorbidities, I would really inquire and think broadly about what's potentially going on there. Like, is it like anxiety? Are they using the tech as like a self-soothing sort of thing? Are they, um, yeah, is it kind of on that addictive kind of side? Like, I'd want to kind of, drill down a little bit and explore other potential diagnoses. Yeah, obviously teaching like kind of like environmental adjustments to, maybe turning turning devices in at night or turning off the Wi-Fi, like all these sorts of other sort of environmental techniques that might help address those sorts of issues.
Thank you.
Yeah.
We have one more question.
Hmm.
Mary asks, what are your thoughts on ADHD clients using medication when they are self-medicating with alcohol or cannabis on a regular, consistent basis?
So using medication, ADHD medication, and self-medicating with
Yeah,
substances.
yeah.
Yeah, I mean, I think having some, yeah, I'd be concerned about that. So definitely having conversations about and assessing their substance use issues and determining if there's a need to refer for more specialized substance use treatment or supports in that realm. I would make sure that I was communicating with the prescriber too, whoever's prescribing those medications, so that they're aware that there's also a potential substance use, um, substance use issues going on.
Gotcha.
Yeah.
Somebody else just dropped one more question in if you have time.
Yes.
Okay. What could be a good list of measuring instruments for ADHD in adults?
Hmm. Measuring instruments.
I'm thinking maybe like screeners or assessment.
Oh, yeah, sure. I mean, I use some of the like the Connor sorry, the brief executive functioning scales. There's the Brown ADHD scales. Uh, those are some that are widely used in the field.
Great. Well, that's it. Thank you so much, Dr. Morrison. This was just terrific. And I don't know if you happen to see the chat going by, but I'm not alone. Many of our attendees also expressed their gratitude to you and their appreciation for the information that you shared. So thank you so much on behalf of the Community Mental Health Board and River Edge Hospital and everybody who attended. Thanks everyone who attended for being here, and watch your email for those links. Okay, thanks so much and happy Friday, everyone.
Happy Friday.